Good morning, everyone, and thank you for joining us today. My name is Mukul Pandya, and I'm the Editor-in-Chief and Executive Director of Knowledge at Wharton. For those of you who haven't heard of Knowledge at Wharton, we are the online business and analysis and research journal of the Wharton School of the University of Pennsylvania. And our mission is to share knowledge from Wharton and other sources with people around the world who need knowledge. And we also aim to bring together experts from across different disciplines to lead insightful conversations on current topics. Today, we are delighted to partner with IIX, also known as the Impact Investment Exchange, for an important discussion on closing gender gaps in healthcare through innovative finance. The founder and CEO of IIX, Doreen Shahnaz, joins me today to help moderate a discussion around women's health in the United States. IIX is a global organization dedicated to building a more inclusive world as the foundation for sustainable peace. They connect the back streets of underserved communities to the wall streets of the world by changing financial systems and innovating solutions for women's empowerment, climate action, and community resilience. Knowledge at Wharton and IIX have been working together for the past year or so to host a podcast series which is distributed through Knowledge at Wharton. And that series is called Backstreet to Wall Street. And we hope that excerpts from today's webinar will also be shared with our global audience of more than 3 million users. And Doreen, thank you so much for joining us today.
Mukul, thank you so much for being on this very, very important webinar. And, interestingly for our listeners, last year when I was attending the GSG Honors Award ceremony in Chicago, and I was accepting the award, and in my acceptance speech, it was very interesting. It was a very emotional moment for me. And that's when, I said, what, IIX is going to really focus on one of the areas of one of the greatest concerns now in the US, which is women's health. And today it's such an honor for me to be joining, by everyone in this webinar, especially our panelists, where this dream is really becoming a reality, and as we drive the progress in women's health across the nation. And as an American woman myself, I'm thrilled to play a role in bringing this important conversation to light, both through today's webinar and also the work that we're doing with all the fantastic partners.
Thanks, Doreen. Really grateful to you for everything you're doing. And I have a question before we start, and that is, to many people, the link between finance and gender equity isn't clear. What research has your team at IIX been doing on women's health and how finance can be used as a tool for achieving more equity in today's healthcare system?
Good question. So actually we have our colleague, our Associate Director of Capital Markets, Natasha Garcha, on this webinar. And she will share with us, and she's right now in California, and she will share with us what she and the team has been doing on our Women's Health Initiative and why women's health is such a crucial conversation to be having today. Natasha, on to you.
Thank you, Doreen. Thank you very much. We're here today because women's health matters. And although the US is the global leader in medical innovation and has been so for decades, gender equity in health is an unfinished agenda. At IIX, we believe no woman should be denied healthcare because of financial or social barriers. With over a decade of experience using innovative finance to empower millions of women across the world, IIX is now building on this movement to bring underserved women in the US to the forefront of capital markets and financial markets through the Women's Health Bond, understanding that women are often worst hit by policy changes and funding gaps by over-reliance solely on philanthropic or public sector funding. And it is imperative to bring the private sector capital into the equation. The Women's Health Bond embraces IIX's mission to connect the backstreets of underserved communities to the wall streets of the world by ensuring that women have better access to affordable, inclusive, and patient-centered healthcare. To this end, in 2018, IIX worked on a feasibility study supported by the Medtronic Foundation, a leader in patient-centered care that is paving the way for more innovation and inclusive care for underserved communities across the nation. IIX conducted 60 interviews as a part of this process with a focus on capturing the voices not just of the funders and the healthcare institutions, but also of the frontline health workers, patient advocates, and women themselves. Through this process, we have narrowed down our focus to 4 women-specific health issues: cervical cancer, breast cancer, maternal health, and reproductive rights. These were issues where we saw a funding gap as well as a tremendous opportunity to enhance health outcomes for underserved women. As a result, we've created a blueprint report with 2 examples on how we can put the bond into practice: a cancer initiative by the American Cancer Society and the Maternal Health Initiative by Columbia University Irving Medical Center, which we will walk you through this during this presentation today. The report will be available online on our website should you wish to download it. To complement the Women's Health Bond, IX also developed a toolkit customized for the US healthcare system that is designed to measure patient-centered outcomes and to serve as a decision-making tool to allocate capital more effectively. The toolkit is based on almost a decade of experience of IX conducting over 100 impact assessments across the world that had helped unlock over $75 million for sustainable development and impacted over 23 million lives.
Apologies to our listeners. I think we're having a bit of a technical difficulty, so just bear with us for 1 second. So I'm just going to jump in because Natasha is having difficulty with her mic. So when we're doing this study, one of the interesting things was, when we really focused on the toolkit, and the toolkit was really about having an approach of looking at a patient-centered care. So for us, it was really important to see that how this impact is going to be measured for the women. So it's through the access, the quality, and the affordability of healthcare, and really looking at it from all 3 angles. And what was also very important for us was to really make sure that 1, the toolkit was patient-centered, and 2, that it is a proactive approach in the sense that not to be reactive, but the patient were actually able to access healthcare before they got sick. And then also very, very important, having a positive incentive structure, for the patient. So again, we saw all of these as essential elements of being able to provide the equitable healthcare, that the women needed. So moving along, what we also did was we said, as we're looking at the toolkit and we're looking at the need of accessing affordable healthcare for women, we really focused on how we can bring this healthcare through a financial mechanism. And the financial mechanism for us was really about looking at a structure that works for the capital markets in the US, and it also works for the organizations that are providing these services and can provide it more and more effective way. So the structure we came up with was, we have termed it as Humanity Bond, where a big focus is really getting funding upfront for preventive and affordable care, and having a way to pay that back later on by a third party who will be supporting this organization. And for the third party, it really is a fantastic way to be able to be associated with the impact when they're not paying the funding, they're not covering the funding for it upfront. So it really is the private sector coming in, we're buying the bond, and we're enabling this. So if you look at this, the structure looks a little complicated, but it's actually not, where the Humanity Bond really brings together very effectively private sector investors and make sure that the healthcare entity who receives it can serve the underserved women. Okay, is Natasha on again? Or should
Yes, I'm back here. So IX reviewed multiple different innovative financial structures to customize the Women's Health Bond for the US context. And based on the findings from the feasibility study, and multiple interviews with both the potential recipients of capital as well as the providers of capital, so that's the investors or the philanthropic funders, we believe the Humanity Bond structure would be ideal. And this is a structure that's been used by the Global Alliance of Vaccinations in Europe to unlock over $6.5 billion of investment capital from the private sector. The diagram that you see on the right side of your screen gives an outline of how the bond would work. Private sector investors would provide large-scale upfront funding in year 1. Proceeds of the bond are used to scale up proven, time-sensitive initiatives that run by a pre-selected healthcare entity that would benefit from upfront funding by saving more lives today and reducing long-term future costs. For instance, providing women with cervical cancer vaccinations or other programs focused on prevention and early detection. A third-party ultimate payer, a foundation or the CSR arm of a corporate, for example, who would have likely supported the cause anyway, would repay the bond through pre-committed funding streams. So instead of paying millions of dollars in year one, they can repay the investors at the end of the bond tenure, which would likely be 5 years or so later. So essentially, we're not just accelerating the funding to improve outcomes for women, we're also reducing systemic inefficiencies associated with constant fundraising by healthcare entities that are currently doing tremendously fantastic work for women's health, but struggle to achieve scale. Do note, this is not a social impact bond. So instead of using negative incentives where investors are potentially not repaid if certain targets are not met, the Humanity Bond uses positive incentives. The full principal is returned to the investors at the end of the bond tenor, and investors may receive an additional coupon if cost savings or efficiencies, rather, are created. This coupon is shared with the healthcare entity doing the work on the ground to encourage and reward the achievement of outcomes by those who can actually control them to some extent. As such, the bonds will effectively unlock large-scale capital from the private sector investors that can complement and significantly accelerate the pace and scale of work being currently supported solely by philanthropic and public sector actors today. Over the coming 5 years, IX will be developing a series of bonds that will collectively mobilize $100 million for women's health in the United States. In tandem, IX will be using the impact assessment toolkit to ensure that there's transparency of results and that, most importantly, women's voices are adequately captured through the process, so we can effectively move from volume of care to value of care. Thank you for your time, and Doreen, I'll hand it back over to you now.
Great, Natasha. Again, apologies to our listeners for a little hiccup there. Natasha, thank you very much. That was a very comprehensive, at least in a very big picture way, but very comprehensive discussion of the work that we did. But I have to emphasize the fact that we actually did not do this work alone. We had really, a village, I would say, who was doing this with us, in the sense that we had 20 industry experts in healthcare, and they were unbelievable, from academia, from the practitioner side, from the beneficiary side, from the policymaker side, all who really helped us in pulling this together and really making us understand and how to really create an effective way to serve women's health sector. So 2 of these experts will be joining us today for panel discussion on women's health. Mukul, I hand it over to you now to introduce our very special guests.
Thank you very much, Doreen, and thanks also to Natasha. That was a very interesting presentation. We are really fortunate to have 2 remarkable leaders today on our panel who have dedicated their careers to advancing healthcare in the US and beyond, especially for underserved communities and populations. Our panelists today are Pouravi Bhatt and Mary Manning. Pouravi Bhatt is the president of the Medtronic Foundation and vice president of Medtronic Philanthropy. She has been with the Medtronic Foundation for 5 years, and most recently she served as the leader of the Global Health and Community Wellbeing portfolios. She has deep experience in global health, philanthropy, and corporate social responsibility. Before joining Medtronic, Pouravi served in global health and CSR roles at Levi Strauss and Company, and also at Abbott. Earlier in her career, she led portfolios in economics and HIV/AIDS at USAID, and served as the Deputy Director of Health for CARE, where she led primary care globally and shaped disaster relief efforts in reproductive health. She holds a Master's of Public Health degree from Yale University and a bachelor's degree in neuroscience from Northwestern University. Pouravi, welcome to the webinar. I also wanted to introduce Mary Manning. She's the Director of Health Promotion and Chronic Disease Division for the Minnesota Department of Health. She has worked for the agency since 1997. The Minnesota Department of Health is the state's lead public health agency, which is responsible for protecting, maintaining, and improving the health of all Minnesotans. The department operates programs in disease prevention and control, health promotion, community public health, environmental health, healthcare policy, and the regulation of healthcare providers. Before this role, Mary worked in a number of leadership and operational positions in the City of Minneapolis Health Department. She earned a master's degree in business administration from the University of St. Thomas and a bachelor's degree in clinical nutrition from the University of Minnesota. And she's also a registered dietitian. So Purvi and Mary, thank you so much for joining us this morning. Before we begin with today's discussion, it would be good to hear a little bit about yourself and your experience as advocates for women's health and also your work within the US healthcare system. Purvi, perhaps we could start with you. You recently were promoted to the president of the Medtronic Foundation, so congratulations for that. The Medtronic Foundation is committed to addressing health issues for the underserved worldwide, and it's a believer in the world community, both public and private sectors, pulling together, multiply our collective actions and strength towards a shared pursuit of global good. I wonder if you could share a little bit more with us about your expertise in the global health space and how the Medtronic Foundation today views the importance of cross-sector collaboration for addressing health inequities today.
Thank you for this opportunity and to IIX and Doreen and her entire team for taking on this important challenge and opportunity in what we see for women around the world, but particularly in the United States. And to your question around expertise and how that translates to what Medtronic is, and our foundation is aiming to do through our philanthropy. I've grown up within the spaces of global health. I'm trained in public health and with an economic bend. And what's been fascinating throughout my experiences that I've been blessed to have is that women have been in the center of the entire arc, whether they are moving forward healthcare as health workers, whether they're caregivers at home, whether they're supporting their families and their communities to ensure that they are healthy and productive. They're in the center, and I think everyone who's on this call realizes that. But over the years, I've seen that while women, and I'm a woman myself, we're often the recipients of a lot of thinking. We're not often brought into the thinking or leading the way, no matter our position, whether we're underserved or have the privilege of serving the underserved. And so it's become really important to really bring not only a patient perspective into this work that we all move forward in global health and in the United States as well, but a woman's perspective. Her health and her vitality is actually the bellwether of community vitality and community health. And so keeping very focused on her, not only for her reproductive moments of her life cycle, but her entire life cycle is key. And so that's been one of the areas that's been important to keep in mind across the years of work and the work that we do here at Medtronic. Multisectoralism has been central in the way that I've grown through the work that I've seen and through the movements that have come in our current day, whether they be in women's health, HIV, infectious diseases. It's no longer can we say that one sector alone is responsible for moving forward health. It requires joint participation, but beyond the rhetorical ways of working, but really balancing things so that we're seeing the variety of disciplines that are needed to advance scale and sustainability of health outcomes, so that we're really bringing forward rigor that's needed from each discipline's perspective, and ensuring that dialogue is well shared and the resources we can bring is well shared, not only in finances, but in thought capital. And that's what we're aiming to do as a philanthropy, is move forward from looking at impact as the focus versus being viewed as a charitable entity or looking at our resources only. And so we're excited here because the work that's presented today really brings that in full view. Finally, I'll say that throughout my career, I've spent so much time outside the United States professionally and inside the United States as a participant of healthcare. And that dichotomy has been interesting to follow. And working now in a private philanthropy, it's been important to be borderless in the way that we look at our work and to be able to bring the United States and what's happening here inside a larger global dialogue so that lessons that are happening in Delhi can be applied in North Minneapolis or in the Bronx or in LA and vice versa. And it's rare to be able to see that porousness of work. And I think what we're doing today is a really important first step to carrying forward how financing and health can come together.
Great. Thank you so much, Parvi. That was really interesting and important, and very grateful for all the work you're doing. I have one question for Mary, who's also a guest speaker from the Minnesota Department of Health. So Mary, you've been working in the US healthcare system for more than 40 years in Minnesota. It's a state that has used legislation to address its many health challenges, including a fast-growing immigrant and significant Native American population with access to quality care. Could you please share a little bit about your journey and the women's healthcare landscape in your state?
This topic is near and dear to my heart. It's always been a part of my work because there is a strange dichotomy in Minnesota. We have just a fabulous state-of-the-art, second to none really, healthcare system in the state of Minnesota, with so many great organizations providing just the best care and such great allied organizations that provide great technology that continues to fuel that. But we also have been a state of great disparities. And I started my career working in a small urban hospital, serving some very affluent, but also some very poor folks. And it was that work, working with some people who needed diabetes care and actually having the opportunity to do some home visiting with elderly and some small work in some urban churches and community centers with women and children, that led me to see, oh my goodness, we were getting some great outcomes working in the community around this hospital, and good outcomes working with people. But, it was really thinly funded and only, funded, just sometimes. And it was so frustrating that I thought, oh my, I have to go get an MBA and figure out how this type of work gets, that we can produce great outcomes and figure out how we can have this type of thing funded ongoing. Because Minnesota does have really excellent health care. And what we need to do is find, how do we get that same health care to everyone who needs it? It's really unbelievable, the disparities that are in our state. In some ways, what we have seen over the last few years are even more distressing. New immigrants actually come into, we have Hmong and Somali immigrants. The Hmong immigrants that came after the Vietnam War have been here for some time, but some of their health outcomes were really quite good when they first came. Now, as generations have been here, and if they haven't attained the economic, haven't achieved really good economic status or educational attainment, which most people have, but they are starting to experience some of the same disparities that the African Americans who are facing wide disparities, and the U.S. African-born populations in our state are facing, and the American Indians in our state are facing. And so a lot of my time has been spent trying to find ways to get women and children who are in those populations who are at risk integrated into the great type of care that we have in Minnesota. And it takes more than just giving access. It really takes having clinical and community relationships built so that people can get to the clinics and get the services that they need and live their lives in a healthier manner. And but that takes, making sure that we're documenting the outcomes, seeing what they are, and it's this type of work is really what I think my whole career has been all about. So I'm very excited to participate in this. And as we talk about the questions, I can be more detailed as we go forward.
Thank you, Mary, and I really appreciate your comments. And now I'd like to hand it back to Doreen to lead the panel discussion.
Thank you, Mukul, and that was a fantastic introduction from both Purvi and Mary. And I mean, it's really remarkable the work that you have done, and the the knowledge and the depth that you bring to the discussion in terms of looking at it from the various angles. And it's interesting, as when we're going through the slides, one of the big things that we really discovered, and both Purvi and Mary touched on it, on what they saw through their work, is that interestingly, the topic of women's health and this whole notion of that women's health really matters, can be narrowed down to 3 really crucial principles in advancing women's health, in the U.S. And frankly, as Purvi, very aptly said, I mean, this is in the U.S., but it really is, frankly, it's applicable everywhere in the world. And also to just really to enhance the gender equity, in the United States. And this approach, the principles are really the 3 of them. We're looking at a patient-centered care, looking at a proactive care, and then also looking at positive incentives. So jumping right in, Purvi, in the recent years, looking at the patient-centered care, there's been a spotlight on transitioning to this patient-centered care across the U.S. And I know you have been, very much, sort of a part of this and pushing these thoughts. So for those who have been tuning in and not familiar with this current discussion in the U.S. and the healthcare system, can you briefly summarize for them what's sort of leading this dialogue and and what has been happening on this kind of patient-centered care in the U.S. and what needs to happen? And what's not happening and what needs to happen?
Sure. Well, thank you. I think some of the things that we've seen around people-centered work around the world, and that's translated into patient-centered work inside of formalized healthcare, is really around taking the end user view. So no matter, again, I'll keep that multidisciplinary lens on this, and that whether you're in human-centered design, working in community development, or working in healthcare, really focusing on what is it that the person that we're trying to serve needs to be front and center. And over the years, particularly in the U.S., and especially in clinical care, that connection point and recognizing what is it that the patient herself actually needs can fall out of being central. And so we've seen over the years, especially as value-based healthcare and outcomes orientation has come front and center, that the outcome is resting in the individual whose health we're hoping to improve. That's where we're going to see progress, is in her opportunity. And so what we've seen over time is that system by system, there's been an intentional look at, if we were to flip things around from the lens of the patient versus the lens of the provider, what kinds of things are necessary? And you start to see a very different patient pathway in terms of how she gets care, who influences her, where she chooses to get care, and then where trust actually resides. And when you understand that larger ecosystem, it's easier for the healthcare system to approach the kinds of outcomes that we need to influence. It's not easy to try and function within that ecosystem, but it certainly opens up the number of players that are involved and how best to engage with them. Most of folks that work in resource-poor settings are very well aware of this, right? They know that trust for healthcare is coming from a lot of informal players and actors, whether in the United States or in other parts of the world. I think what we're seeing now in patient-centered care within the United States in particular is a real appreciation of the formal system coming into that space, and then starting to know that as more and more evidence comes into play, the opportunity for reimbursement also increases so that we can actually get that view financed. But in order, I'm just bringing it right back, in order for value-based care to get beyond the rhetoric of value-based care and really in the hands of true value to those that we're aiming to serve, the outcomes that we're aiming to deliver need to be brought through the voice of patients. And you've seen this even in the work that you all have moved forward together with us, in noting that taking that view is not streamlined or hardwired yet in the way that any of the work that we move forward moves ahead. So even in looking at building a toolkit, even in looking at putting a task force together, even in looking at getting qualitative insights, we have to be really intentional to ensure that she's involved as a health worker as well as a patient. And I think that first step is critical, and really congratulate you all for taking that step with us.
So Purvi, so I guess, I mean, you touched on a lot of very important issues here. And I think, just really, as you said, making this shift from volume to value. I think one of the big things, and having the voice of the women in it in terms of the outcome. I mean, one of the big component, of course, is measuring that outcome. So, as a health, measurement expert, I mean, how can we look beyond, just looking at the access to care to truly measuring and magnifying, the quality of care? I mean, how do we flip this?
I think, and I think this is open space for a lot of folks who are looking at this now from a different view. But the perspective of bringing, triangulating qualitative and quantitative information is key. Again, the dynamic tension of different disciplines working together is really important in this, right? No one discipline, lays claim to rigor, right? No one discipline lays claim to outcome. But it's an insidious thing as disciplines come together to start to worry about volume before value, because we're driven to do that. And so in getting back to value, it goes even beyond quality of care. It goes into really recognizing what does it take for a woman to step into her own health and get the care that she needs, and then presume that quality will be there when she arrives. And that, in order to measure that, I think there are different measures that need to be brought in. Engagement, they're softer measures. Sometimes marketing can be interesting in looking at some of the metrics that are available there. How engaged is she? Who's actually helping her get connected to healthcare? What's the lead time and lag time to getting her to where she needs to be or where she chooses to go? How are we shortening that space? What are some of the efficiency measures that can be proxy for what she needs as well? So I think it's being much more creative in how we think about what outcomes look like. And then volume will matter, of course, because we want more and more women to get the care that they need, but only if we ensure that it's really meeting her where she's at and starting there.
Very, very good insight. Mukul, do you want to ask Mary about the next important topic in this space?
Sure, absolutely. Thank you, Doreen. So Mary, while Minnesota, as you said before, typically outperforms on all national healthcare benchmarks, we still see preventable conditions such as cervical cancer cases remain particularly prevalent, particularly among ethnic minorities and rural women. So how can we make sure that we are supporting programs that support prevention and early detention among these communities? So any thoughts on that?
That's a really, really good question. And I think one of the things that we're trying to do is actually kind of building on what Purvi said is we're actually looking at trying to pilot exactly what she was talking about, doing these like learning circles and working with small different clinic populations and trying to using, step by step, exploring like a partnership with, say, our University of Minnesota. And so we have a really biased evaluator and working with a couple of communities and really trying to go through a number of different questions to evaluate participants' knowledge and attitudes about topics. And then really looking at short-term and intermediate outcomes and looking at changes over time as we do work in that community and working with the clinicians in that community along with the healthcare team. We, in Minnesota, we have healthcare homes, and that's a certification where we're trying to get, where clinic groups will get are employing a team-based approach to trying to get better healthcare outcomes. So that will be a social worker, a nurse, and other people as part of the physician team, and a community health worker, and financial folks as part of the team. And they will be participating in and learning from what we hear from these circles. And, as time goes on, when we're looking at the other outcomes, the clinical measures, we're also going to see what happens with those measures, in years coming, as we've gone and done the work in the learning circles with the women outside of the clinic. So using what we've learned, we're trying to change the interactions. Some of the things that Purvi was mentioning, the how it is that you get to the clinic, what your clinic experience is, and what your knowledge about the importance of the preventive care is, because it's very hard for some of the women who are experiencing some of these at-risk outcomes to really make this a priority. So we really have to look at how do we change our practice in order to make it more convenient for them, because it will benefit them in the long run. So that's basically what we're trying to do. And as we find best practices, as we get evidence-based interventions, we are trying then to roll that out to other clinics where we don't have to necessarily go through all the processes. It's more of a pilot, and then we try to get those same practices out further to other clinics in other parts of the state. And we are right now in the midst of doing that with our breast and cervical cancer program. And there are rural clinics and community-based clinics that we're actually doing that work in right now.
Thank you, Mary. I have a quick question for Purvi, and that is, some time ago, when Doreen and I had interviewed the CEO of Medtronic, Omar Ishrak, which we published in Knowledge at Wharton, he had said that one of the challenges in meeting the healthcare needs of the underserved in the US is creating sustainable funding. Now, as the head of the Medtronic Foundation, why do you think it's important to use grant funding to unlock more private sector capital? And specifically, I wonder, how you see the role of mechanisms like the Women's Health Fund.
Thanks. No, it's the essential question anywhere in the world is how do you unlock capital? And we know in global health, maternal health, and reproductive health, and more broadly, women's health has gotten a good bit of focus and investment through public sector donor dollars, and then of course accompanied by private sector as well, and then local investment is growing. What we're seeing here, especially as you move into rural areas, there isn't as much financing as one would hope. And so what Omar is saying is absolutely right. Especially when looking at capital growth, it is a tricky space to move into. And we also know in the United States in particular, outcomes orientation, evidence-based work leads in being able to unlock the capital that's needed if we want things like reimbursement programs and the rest to come into play. And so those are some of the factors that I believe are driving what's happening with the lack of access to care here. The role of philanthropy broadly, and then I'll come to corporate philanthropy, which is a unique subset of philanthropy, is to spark and bring about new ideas that with some open space so that they can be explored. And then with limited capital, which tends to be the case with corporate philanthropy, really figure out with a sharp point how to advance the field in a particular way with the hopes of bringing others into the space. So our example today around the toolkit and really scrubbing in on what are the outcomes that we could try and bring about in women's health, especially for the underserved and particularly in rural areas, is with that in mind. What is the information that we know? What don't we know? How have we tried to gather this insight and what's new in that, like bringing a patient-centered and a women-focused view, and balancing the scales when we look at different financing insights with those that actually have health outcome insight. And that balance isn't something that happens routinely everywhere. So when you're looking in healthcare today, it is now a much more blended and crowded space with a lot of different actors coming into the fray. What we don't yet know is the overall envelope actually growing, or are we swapping each other out? And what we're all looking for is growth. And so in order to get to growth, we have to really place the right kind of assets in the right placement to ignite the kind of growth that we're looking for. And in the US, I think with rural health in particular, that is an open space that we would love to chase into if we can see that there's other opportunity that our participation can unlock. So by providing evidence, by helping the bond come together with evidence, primarily in the hopes that others will see the opportunity, it will be essential. The main thing is to ensure that we're delivering on the kind of evidence that's needed in healthcare. You know, for us, do no harm first has always been our ethic, and in doing that, we have to get the right data together. But then also making sure that the right landscape analyses are happening so that we understand who's interested in ensuring that rural healthcare for women grows. We know the data is really, really bleak in terms of what's happening for women in the rural spaces. And if we're going to get to value-based healthcare, we need to grow there. And so we're hoping that this will attract others. But the main thing is this can't be a zero-sum game. We need to bring in others that are actually wanting to grow, and so that we're not swapping resources when we discover and consider blended financing.
Purvi, that's a really good point. And I think also just for our listeners, I think it is very interesting. We do need to be mindful of the fact that, you know, obviously blended finance is playing a bigger and bigger role, but also in all of this, what does timing, you know, mean in all of this? So it's not just swapping one capital with the other, but how does one unlock the other? And what can be done today in terms of prevention, where private sector capital can come in, and then perhaps the philanthropy capital comes in later. So it is really different ways of looking at it, which really didn't happen before. So which is all very, very exciting. And just to wrap up, Mary, I mean, I would like to find out a little bit more from you, because I know you have you know, immense experience in this, in terms of really seeing, you know, how does positive incentives or even negative incentive, I mean, how did this sort of work in this whole sector? I mean, to bring various stakeholders in and the voice in?
Well, it is very important to have the financing and the and actually even the involvement of various stakeholders and resources in these projects, because without it, it just doesn't happen. For many of the initiatives that we've had, it takes a lot of, especially we're finding in the rural area. We have just had an experience where we have done some great work. I know this isn't exactly on the same topic, but we've been training rural hospitals to respond to strokes, and we've decreased the stroke time from 90% of from 60% of the outstate population to 90% of the outstate population getting 30-minute stroke time. I know this isn't exactly the topic, but it's the type of thing that happens all the time. We've got it down in 6 years. We've got it to from 90% of the population having 30-minute time from the 60-minute time. I mean, from 60% of the population. But we have to continually do that because there's changes in the landscape out in the rural area, because the clinics change all the time because of we can't just, that's not done now. The clinics are changing, they're merging, they're closing, different providers are only there for 2 years. It's just so, companies are there at different times. Health people who are providing daycare, school systems, everything is so in flux in the rural area. The things that support the women who work there, the things that are supporting communities and families. So even something that's actually is much more tangible and easy to do, like work with the emergency rooms, So it's much harder when you're trying to work with setting up the ability to do reproductive health, when you're trying to do preventive care for women, that just isn't getting the same type of reimbursement and the same time of attention. And, you don't have the support of women having places to take their children, even for daycare. We don't even have, in a lot of these rural areas now of the state, having women have the ability to stay there and become employed because of the ability to take their children to daycare. There's such a lack of daycare.
I think, Mary,
the amount of challenges are just immense.
I think you're spot on, and I think in terms of, again, the incentive that are needed, it just obviously having the patient-centric approach, but also looking at the entire ecosystem that's around the patient as well, to make sure she can actually make use of that incentive. So I think there's a lot to be done, but the good news is it's the work is starting, and we hope that we can all be part of this and making this happen. On that note, Mukul and I would really like to thank very deeply our fantastic panelists, Purvi Bhatt and Mary Manning. And we would like to sort of jump in and for our listeners and really encourage them, all of you, who are on the call, to also take action. As you saw from, heard from our panelists, I mean, they've dedicated their life to it. And what we have seen from our work is there's a lot to be done, but the good news is we all can be part of it. And so very simply, you can literally go to our website at ixfoundation.org/advancing women's health, as you see at the bottom of the screen. And you can endorse the principles. There's always the beginning, just say that you want this, right? So that's when you have the policymakers sitting up. That's when you have the private sector group saying, oh, okay, fine, maybe we should be thinking about this. So please endorse the principle. Share the patient survey. If you're a woman who is actually getting the care, we need your voice. We need for you to say what you're experiencing, say what you want. So please, share the patient survey. And if you are with an organization who can be part of this on an organizational level, please be part of our phase 2 of our Women's Health Bond, where we now are looking to start a structuring of a bond. And let's make this happen. This is, we see the need, we see the way to do it. We see how we can really change the system from volume to value to make it patient-centric. So please be part of this. This is really a very very important, quiet movement, I believe, that is starting on here. So be part of it. So now I'm going to open it up for questions. And we have a question here from one of the attendees. I agree that prevention and proactivity is important for advancing women's health. Can you share what an innovative financial product that addresses proactivity and prevention may look like? Well, we touched on that with our Women's Health Bond, but maybe Natasha, do you want to kind of touch on, I know you and the team found a lot of different examples. Do you want to share one of them with our listeners?
Yes, that would be great. If we could move to a slide with an example, please. Great. So I think there are 3 things to look at when you're talking about proactive healthcare, and it's what you fund, when you fund it, and how you make sure that it remains patient-centric and you have the voice of women involved, as Doreen, Mary, Anna, and Purvi have all mentioned is important. So this is an example of cervical cancer case by American Cancer Society. In terms of what we're funding, it would be to scale up an American Cancer Society HPV vaccination program, potentially in the state of Minnesota, with the objective to reduce cervical cancer incidence among underserved women. This is based on a pilot. It is a proven initiative that we would scale up by accelerating the upfront funding that will undoubtedly save more lives today, but also very importantly, reduce future costs, not just to the women in terms of financial and social costs, but also to the healthcare system itself, who has to then focus on treatment if we don't fund prevention today. And the cost of treatment, of course, is much larger. In terms of when we funded, as you can see, the private sector investors would come in upfront in year one to unlock, say, for example, in this case, we've said $10 million to really roll out this program at scale today. And this is important because we are unlocking the 10 million today, as opposed to doing this, say, over the 5 years of the bond. So one of the biggest issues we found when we spoke to healthcare providers is that every year you have to go in and invest a lot of time, money, and resources to raise funds constantly. And that's why many programs don't actually get scaled up, even though they've had successful pilots. So in this case, you would see a supporter of the program, so maybe a corporate CSR arm in the state of Minnesota would come in to pay this off at the end of year 5. And instead of paying $10 million in year 1, which most CSR arms or foundations typically cannot and will not do, we get the funding upfront from the private sector investors, and it's repaid at the end. So there's also the idea of having time value of money and having a reliable source of funding for American Cancer Society to scale up their work today. And finally, in terms of how do you make sure it's patient-centric, before we even go into funding this, we would use the impact assessment toolkit to make sure that we can do upfront projections of what we would fund, how we would create patient-centered outcomes, not just access of care, but making sure there's equity, that women of color, undocumented women, and women in rural communities are given access to healthcare, and that this is an affordable program that can be sustainable over the long run. So we do an upfront impact assessment, and across the life of the bond, we make sure that we're reporting this to the investors and to all the other stakeholders involved, which creates accountability and transparency of results. Finally, as with our other bonds that we've done in other parts of the world, this could potentially be listed on a stock exchange, which is a very important step for bringing women front and center to capital markets by bringing liquidity into this space and making a real case for going beyond philanthropy so we can view in women's health as a good investment case. So that's one example of how we would do this and how it would align very nicely with all the principles that we laid out earlier in the presentation. I hope that's helpful.
Great, Natasha. No, that was really, really helpful. And we have a few other questions, but I'm conscious of time. So we unfortunately need to wrap up. So I would like to thank all our panelists. I would like to thank Mukul, Knowledge at Wharton, who obviously has been an amazing partner. Thank you so much, Mukul. And our amazing panelists, once again, Purvi Bhatt and Mary Manning. Natasha, thank you very much for sharing the research. And I would like to thank our team here, who it's very late at night in Singapore, where we are doing this from. So Jocelyn Mateus and Siddhant Pramanik, who is sitting here with me doing this. So thank you very much, guys. And I would like to thank, of course, from bottom of our heart, Medtronic Foundation, because none of this would have happened if Medtronic Foundation wasn't there to support our work and be there with us, throughout. So thank you very much, Medtronic Foundation and Purvi for believing in our work. I would like to put in a word about our San Francisco event. So this is happening next month. So we're very excited about it. All of us will be there. And this is going to be happening on October 24th, which is the United Nations Day. So please do join us. And the topic will be a very interesting one: women, peace, and parity, using finance as a tool for progress. So this will be very interesting, trust me. And of course, fantastic view of the Bay. We'll be doing this at the Wharton campus in San Francisco. We have a number of speakers. It'll be a fantastic panel, and we look forward to seeing many of you there. And we'll find more about it in our website. So thank you again to our listeners. Thank you to our panelists. Thank you to Knowledge at Wharton, and we look forward to seeing you again in October.
From Knowledge at Wharton's side, I just also wanted to, completely endorse everything that Doreen said and thank all of you. It's been a real pleasure to collaborate with all of you on this. This is an incredibly important issue for all of us to focus on. I just as a personal note, I would say in conclusion, that women's health is, not just a women's issue, it's a human issue. and men and women together should work together on everything that we've talked about. Thank you all very much.